Hello everyone. Today's topic of discussion is on neck swelling. So before starting the neck swelling, I would like to show you from this diagram about the different spaces in your neck. So in your neck, if you divide this spaces, please understand this diagram very well clear and make your own diagrams. See, so if you look into this diagram, you can understand that you have in between the anterior belly of the digastric and the posterior belly of digastric. Okay, so first of all, you have anterior belly of digastric and posterior belly of digastric, and then you have a hyoid bone. You have a hyoid bone, and at the back you have this sternocleidomastoid muscle. Okay, so here if you just move here like this muscle over here, this is the sternocleidomastoid muscle, right? So you have the sternocleidomastoid muscle. Here you have the anterior belly of digastric and posterior belly of digastric. Okay, and over here you have the anterior portion, this portion is the anterior portion. Then downwards you have the clavicle, like this. Okay, and what you need to understand is anteriorly over here you have the muscular triangle, this one is the muscular triangle. Okay, this is the anterior belly of digastric, this is the posterior belly of digastric. This triangle which lies below the chin and between the anterior belly of digastric and posterior belly of digastric, this triangle which I am marking now with black, this is actually the digastric triangle. You have sternocleidomastoid muscle over here, right? And posterior to the sternocleidomastoid muscle, you have this one is your superior belly of digastric, and here this is your inferior belly of digastric. Okay, inferior belly of omohyoid. Okay, omohyoid. This is superior belly of omohyoid. And this inferior belly of digastric, it divides whole of this cavity into the suboccipital triangle and the supraclavicular triangle. The posterior portion, it has suboccipital and the supraclavicular. Supraclavicular means above the clavicle, and suboccipital means below the occiput. So below the occiput and above the clavicle. Are you getting this diagram? Below the occiput, you have the suboccipital triangle, and above the clavicle you have a supraclavicular triangle. Okay, and in front of this one you have one is the muscular triangle which is bounded posteriorly by your superior belly of digastric this way, and anteriorly you have the skin. Okay, skin and fascia, and this one is your anterior belly of digastric and posterior belly of digastric. In between them you have the digastric triangle. So I hope you got this from this diagram. So this is just a gist to understand neck swellings. So the first and foremost topic that we would like to start today is on cystic hygroma. So we will start today with cystic hygroma. So what is cystic hygroma? Cystic hygroma is actually a lateral neck swelling. Okay, it is a lateral neck swelling. It is seen usually in the posterior triangle of the neck. Okay, so this can be seen in antenatal diagnosis also. First I'll speak and then we will learn. Okay, so if you understand about cystic hygroma, cystic means having cystic spaces, right? It has cystic spaces. This cystic spaces must consist some fluid, right? So that fluid comes from the jugular lymphatics. It actually imbibes the fluid within itself. And it's a cystic swelling, so it's mobile and it's palpable. And you need to remember that if I put a torchlight and if I just see the swelling, it is brilliantly translucent. We'll write everything, okay? Don't worry. It is brilliantly translucent. One more thing you need to understand about cystic hygroma is any patient who is having cystic hygroma may have a history of obstructed labor. There might be history of obstructed labor. And cystic hygroma is also a radiological diagnosis where you can actually diagnose cystic hygroma with the help of radiology. Okay, with the help of radiology. Now, what do you need to remember more? You need to remember that jugular lymph node, I already told you jugular lymphatics. Although I told you the posterior triangle of the neck, although I told you difficult labor, although I told you this can be congenital, or this can be seen 1 to 2 months after birth also. Okay, so it can be present at birth also, or it can be acquired later. Now, most common site is the posterior triangle of neck, but it can be also seen in the other spaces also, and that can be remembered by the mnemonics AMIR, AMIR, AMIR. Okay, AMIR, that is axilla, mediastinum, inguinal canal, and retroperitoneal region. retroperitoneal lesion. So I hope you are getting this right. So let's get the concept well clear. Okay, let's get the concept well clear. Now, whenever we talk about cystic hygroma, it is a condition, it's a congenital condition. It is multiloculated cystic spaces you can see in this area, okay. So multiloculated, write it down, multiloculated cystic spaces, okay. It can be congenital or it can be seen later at birth. Now remember that cystic hygroma can also be, I already told you that it imbibes the jugular lymph sac, okay. So there will be sequestration of the jugular lymph sac, okay. So there will be sequestration of jugular lymph sac. Sequestration of the jugular lymph sac. And it is brilliantly translucent. Okay. Now it's lined by the endothelial cells. And it tends to imbibe the lymphatics within itself. Okay. And it is associated with Turner's syndrome. In 50% of the cases, it is present at birth. Then there will be difficult labor. If it is present at the birth, there will be difficult labor. Now you need to remember that cystic mass, it causes air obstruction. So there can be airway obstruction because of that cystic mass. Because of that airway obstruction, because of the cystic mass which has caused airway obstruction, there can be dyspnea. There can be series of, there can be actually, the child might have, difficulty breathing. Okay. So all these features may be seen if it's enlarged enough to compress the trachea, right? Now what you can know that it is, of course, it's a cyst, so it is soft and it is compressible. It is soft and compressible. So of course, it's a cystic mass, so it will be soft and it will be compressible. Remember that there will be hemorrhage and infection associated. There might be hemorrhage and infection associated. Now remember that the child coughs and cries. If the child coughs and cries, the size will increase. So write it down. If the child coughs or cries, the mass increases in size. Okay, the mass, it increases in size. Okay. Next thing that you need to remember is the overlying skin. It may be blue or it might be normal. Okay. I told you that this is brilliantly translucent. It is brilliantly translucent. Can you say any other condition in ENT where if after the child cries or because of certain valsalva, there's an increase in the mass? So it's a mass of the nasal cavity. It's a congenital mass in the nasal cavity. Can you say it? It is meningoencephalocele. Okay, meningoencephalocele. In meningoencephalocele, what happens is, in meningoencephalocele, the mass, it increases when the child cries. Okay, or it might also be seen when the child coughs, the mass might increase in size. Okay. Next is, so you can go for a USG, and USG also helps in antenatal diagnosis of cystic hygroma. This is also important. Now treatment, it will spontaneously regress. So there will be cases where cystic hygroma will be spontaneously regressing. If it doesn't regress, you have to go for injection. Bleomycin. Bleomycin is actually an anti-neoplastic drug. Or you can also go for PC-Banil. It's also given by the OK 432. Okay, it's also known as PC-Banil and bleomycin. Okay, and if there is stridor associated, because of the very big mass, there might be stridor associated. For that case, you have to go for a Yes, emergency tracheostomy. And if the infection persists, so if there is an infection, hemorrhage, cystic hygroma associated infection, so there is cystic space, and there is there is infection also. What you need to do is you have to give IV antibiotics and you have to drainage. IV antibiotics and drainage must be done, okay? And 50 to 60% it is present at birth, and 80 to 90% of the case it can present at till 2 years of age, okay? Till 2 years. From birth to 2 years of age. Remember, 2 years is actually a marker for laryngomalacia also. Till 2 years, we'll look in any regression of the inspiratory stridor for laryngomalacia. If in case the laryngomalacia is not treated or it doesn't go by 2 years of age, we have to go for supraglottoplasty, that is epiglottoplasty. Next, look for tracheal deviation. Look for cyanosis. Airway obstruction, feeding difficulty, and failure to thrive. And on CT scan, there is a contrast enhanced CT scan, CECT, where you can see that whether the cyst is a macrocystic or it's a microcystic, okay? Whether it's a macrocystic or it's a microcystic. So if it is a macrocystic, it means the cystic spaces is more than or equal to 2 centimeter. Again 2 years, till 2 years it can be seen. 2 years laryngomalacia, 2 years cystic space, okay? Less than 2 years, 2 centimeter. So best investigation is CT scan. The best investigation is CT scan. So let me summarize cystic hygroma for you. Cystic hygroma is a condition which can be seen at birth, or it can be seen till 2 years after birth. So it can be microcystic or it can be macrocystic. Microcystic means less than 2 centimeter is microcystic, more than 2 centimeter is macrocystic. So it might be present at birth, and if it is present at birth, there will be history of obstructed labor. If you talk about cystic hygroma, it's a mass at your posterior triangle of the neck, and when you just examine that using a light, you can see that it will be brilliantly translucent. It will illuminate, okay? Okay, and of course you also know that hydrocele also eliminates, okay? And also if you eliminate the this one, meningocele and meningoencephalocele, if you eliminate, they are eliminating, okay? And the sign I told you that if the child cries, it will increase in size. Remember, if the child cries and if this meningoencephalocele and meningocele, if it increases in size, that is known as Frutzenberg sign, Frustberg, Frutzenberg sign, okay? Frutzenberg sign. Please look into the spelling again, okay? I might be wrong also, but it is associated with Turner's syndrome. So it is only seen in the neck? No, it can also be seen in other sites. We can remember it by the mnemonics AMID. A for axilla, M for mediastinum, I for inguinal, and R for retroperitoneal area, retroperitoneal region, okay? So it will spontaneously regress. If it doesn't spontaneously regress, we can go for injection bleomycin, or we can go for PC Banil, okay? So this was about cystic hygroma. So let's go to the next topic. Do you want to see the slides? Yes, I have the slides for you. So this was about ranula. I'll talk about thyroglossal cyst also. For now, I want to talk about cystic hygroma. Yes, look here. How beautiful the picture is. Cystic hygroma. Swelling at the posterior triangle of the neck, and it's a congenital benign multiloculated lymphatic lesion. It's found in the posterior triangle of the neck. Other sites are AMIR, okay? Axilla, mediastinum, groin, inguinal, same thing, and retroperitoneal. Failure of lymphatics to connect to the venous system, and abnormal budding of the lymphatic tissue sequestrated by the lymphatic cell rest. Yes, sequestration of the lymphatics. It means sequestration of the lymphatics. Clinical presentation, it might present at birth or it might present by 2 years of age. Okay, it's a soft, painless, and it's a mobile mass, transilluminated mass. Okay, and it's overlying the skin. The skin may be blue or it's maybe normal. Sudden increase in size due to the intracranial pressure or infection. Increase in the intracranial pressure, sudden cries, or sudden intercystic bleeding, or sudden infection can actually lead to increase in the size. Look for tracheal deviation, airway obstruction, cyanosis, and feeding difficulty, or any failure to thrive. So you can go for USG for diagnosing cystic hygroma in utero. If in case you haven't diagnosed it in utero, you can of course go for CT scan. Macrocystic means more than equal to 2 centimeter, and microcystic means less than 2 centimeter. But the best diagnosis is an MRI. Okay. So what we do is we just wait for some time, and after that we go for injection bleomycin or PC-Banil, ethanol, doxycycline, interferon. So if it's an infected case, you have to go for an antibiotics and drainage, and surgical drainage excision remains the mainstay of treatment. Okay, so done with cautery, laser, or radio frequency. Okay, so surgical treatment can also be done. Okay, if in case it persists, you have to go for surgical treatment, and if in case it's a stridor case, you have to go for emergency tracheostomy. Okay, so there is no thank you. Now I will talk about the next very important topic, hypopharyngeal pouch. So what is hypopharyngeal pouch? It's very easy. I'll just speak up here only. So hypopharyngeal pouch means basically it's an area of Zenkus diverticulum. There can be other diverticulum also, but the most important is the Zenkus diverticulum. It is a pseudo diverticulum. What is a pseudo diverticulum? Pseudo diverticulum means it is a pseudo diverticulum means it does not have all the layers. Okay, it does not have all the layers of the it lacks all the layers. There might only be some layers. Okay, and hypopharyngeal pouch or Zenkus diverticulum is seen because of the excessive contraction of the cricopharyngeus muscle. So you have two muscle, one is thyroglossal muscle and other one is the cricopharyngeus muscle. Okay, thyroglossal muscle, it goes obliquely, whereas cricopharyngeus muscle, it is straight. Okay, now what happens is whenever there is a sudden contraction of the cricopharyngeus muscle, there will be this area of weakness. Wherever there is this area of weakness, it will actually come outside. Okay, it will actually come outside. Okay, at the area of weakness, and sudden, the age group is about 50 years. Okay, around 50 years, and whenever there is eating, okay, or whenever you just palpate the mass, there might actually be a certain gurgling sound. Okay, certain gurgling sound. Okay, and that is known as Bowes sign. Okay, Bowes sign. Now you need to remember that there is something which is known as Bryce sign also. That is basically whenever you just touch the cricoid, and it whenever you move it, there is one Bowes position. Okay, Bowes position. This is there is one sign. This is a Bowes sign. Okay, it's okay, gurgling sound. Okay, now this is one Bowes position, or this is also known as barking dog position for laryngoscopy. Okay, I was about to say this Moore sign. Okay, it's Moore sign. This is Moore sign, M-U-R-E, Moore sign. Other Moore sign is Irwin Moore sign, which is seen in the case of chronic tonsillitis. Okay, there are different signs which the spelling it resembles. So the spelling has become so important. I also tend to forget the spelling sometimes. Okay, so let's come back to the topic. So cricopharyngeus and thyropharyngeus. Thyropharyngeus and cricopharyngeus are the muscles of the inferior constrictor. You have superior constrictor, middle constrictor, and inferior constrictor. These three constrictors are the muscles of the pharynx, whereas you have longitudinal muscles also like salpingopharyngeus, palatopharyngeus, and stylopharyngeus. These are the longitudinal muscles. But now we are concerned about the inferior constrictor, that too thyropharyngeus and cricopharyngeus. Okay, thyropharyngeus also attaches to the lateral, the oblique line to the thyroid cartilage. Okay, now you need to understand that whenever there is so much contraction of this cricopharyngeus, what happens, it comes out bulging from this area. Okay, and you can see that there is a mass over here. There's a mass over here, neck mass. Okay, and the person complains that he has certain halitosis. So why will he have halitosis? He will have halitosis because of the undigested food which is present in the pouch. Okay, so there's undigested food present in the pouch that might actually go that might becomes a hub for anaerobic bacteria to grow, and there'll be of course halitosis also. Person complains of mass, and there is a gurgling sound also. Okay, so how are you going to treat this condition? You can go for endoscopic stapling procedure, which is known as Dolman's operation, or you can also go for surgical excision of the pouch. Okay, so let's go on to the slides. So hypopharyngeal pouch is an acquired pulsion diverticulum Olson diverticulum, okay, caused by posterior protrusion of the mucosa through pre-existing weakness in the muscles layer of the pharynx or esophagus. So this area of cricopharyngeal, there's a cricopharyngeal, and this is the area of hypopharyngeal, okay. And this area of Zenker's diverticulum, this is actually an area of Killian's dehiscence, okay. Now this downwards is a longitudinal muscles of the esophagus, okay, longitudinal muscles of the esophagus. So let's move on to the slides for hypopharyngeal cancer, hypopharyngeal pouch. And of course, we have already discussed that it is also known as Zenker's diverticulum, and all the extra points we have already discussed. So in the first module. So I will also like to say you that whenever we talk about this one, if there is any dehiscence in the cricopharyngeus, it is known as Killian's dehiscence, okay. Zenker's diverticulum is that hypopharyngeal pouch, okay. But if it is any problem in the cricopharyngeus muscle, and if it comes out, that is known as Killian's dehiscence. And there can also be dehiscence in this around the circular muscle of the esophagus, and that is known as Lamier's dehiscence, okay. Lamier's dehiscence. Lamier's dehiscence. You can remember that L for Lamier's and L for longitudinal muscles of the esophagus. So there is longitudinal muscles of the esophagus and there is Lamier's dehiscence, okay. You can remember in that way. Tonic spasm of the cricopharyngeal sphincter, like in the case of gastroesophageal reflux, okay. Lack of inhibition of the cricopharyngeal sphincter, neuromuscular incoordination between the thyroglossal and the cricopharyngeus, second swallow against closed cricopharyngeus, okay. The basic pathology, the basic condition of all these four is one, that is a tight cricopharyngeal sphincter, okay. If there is a tight cricopharyngeal sphincter against a tight cricopharyngeal sphincter, there is actually a formation of a diverticulum. It might be from a second swallow mechanism, or it might be neuromuscular incoordination, or it might be just because of the tonic spasm of the cricopharyngeus muscle, okay, or it might just be a lack of the cricopharyngeal sphincter relaxation. So there is no relaxation, just a spasm, okay. And what you need to remember is entrapment of the food in the pouch, sensation of food sticking in the throat and lead to dysphagia. Yes, regurgitation of the entrapped fluid, foul taste, bad odor, which is basically known as halidosis, nocturnal coughing, choking, hoarseness of voice can occur because of laryngitis, associated laryngitis, okay, laryngitis. There can be pharyngitis, okay, because of the food. Weight loss can be there due to malnutrition, and there will be certain pouch, okay, on your neck, okay, neck swelling can be there, and that's known as Boyce sign, B-O-Y-C. There is Boyce position, Boyce sign, okay. Complication, lung aspiration can be there, bleeding from the sac mucosa, absolute esophageal obstruction, fistula formation into trachea or major blood vessels, and squamous cell carcinoma with Zenker's diverticulum. Within the Zenker's diverticulum, yes, they can also be. It can also result in tumor. And to differentiate it, you just go for a MRI, and you can see that if there is the sac is well defined like this, it's a well defined sac. There is no corrugations or there is no distortion of the sac. It's just a pouch. But if there is corrugations and if there is distortion, then it can be a squamous cell carcinoma, okay. So next is barium swallow can be done, rigid esophagoscopy, flexible endoscopy, chest x-ray. See, barium swallow, you can see a beautiful pouch out here. See, if you can see here, you can see that in barium swallow also you can easily see that the lining is smooth, okay. Surgical treatment is, one is Dolman's operation, as I already listed, right, stapler procedure, and you can also go for removal of this one. And remember that the cricopharyngeal muscle is very much tight, that is why you're having this problem, right. So you have to go for a cricopharyngeal myotomy. This is most important, okay, cricopharyngeal myotomy, and it's combined with other procedure like diverticulopexy. Diverticulopexy means, suppose this is your esophageal inlet and this is your cricopharyngeus. What you do is you just staple this in such a way and you make this pouch a one pouch, okay, one pouch. So whenever food goes here, it will eventually go here also. You make it one pouch, okay. Or what you can do is you can just cut this and remove this, and then you can just make the esophagus like this. Okay, just cutting or removing all this portion, and you can make it as a single lumen. You have cut this part. Okay. So treatment protocol: cricopharyngectomy, pharyngeal myotomy plus minus invagination, open diverticulectomy. So just understand the basic concept that there is Dolman's operation and Zenker's diverticulum. You need to understand. Okay. So next, very important, is actually your laryngocele. Laryngocele can also be congenital. It can be acquired, and it is usually seen in those individuals who are really to the profession of glass blowing. Okay, they are to a profession of glass blowing, and they also have a profession of or it can also be seen in other professions, like it can be seen in the case of trumpet blowers. Okay, it can be seen in the case of trumpet blowers. Okay. And it is a condition which is also seen in other conditions. It is a condition where there is accumulation of air in the laryngeal saccule. So we know what is saccule, right? So we know that the larynx is divided into the laryngeal inlet, the supraglottis, the glottis, and the subglottis. Okay, the larynx is divided into supraglottis, glottis, and subglottis. So this occurs at the area in between your true vocal cord and the false vocal cord. At the area of the true vocal cord and the false vocal cord, actually I'm trying to find my notes also, but indeed the thing is, okay, let it be. So in between the area of true and false vocal cord. So is there any diagram to explain? So okay, understand in this way. Okay, I'll write it over here itself. So suppose this is your quadrangular membrane and this is your conus elasticus. So this area in between the true vocal cord and the false vocal cord, you just have this saccule, right? And there is air entrapment inside this, and this is known as laryngocele. Okay, this can be congenital, this can be acquired. So arises from the expansion of the saccule of the laryngeal ventricle. Okay, first of all, what do you have? You have the space. You have a space. That space is known as laryngeal inlet. Then you have the supraglottis, right? Supraglottic area is known as the vestibule. Okay, vestibule. Area between the true vocal cord, it is known as rima glottidis. In between the true vocal cord and the false vocal cord, it is known as ventricle. In between the false vocal cord, it is known as rima vestibuli. Very good, rima vestibuli. Okay, so occupational, like trumpet blowers and glass blowers and trumpet players, it can coexist with larynx cancer. And it's seen in 6th decade. It's unilateral in 85% of the cases, and 1% consists of carcinoma. Male to female ratio is 5:1. Okay, male to female ratio is 5:1. Now the swelling, it enlarges on valsalva. It was also the cystic hygroma also it enlarged during valsalva, but child, they cannot do valsalva, right? So the only way to increase the pressure is either by crying. Okay, crying. So it can be an internal, external combined. See, internal means totally it is towards the endolarynx. Okay, external means it's a pouch which is seen externally. Okay, and combined, it looks like a dumbbell, right? So other dumbbell we studied in the case of deep lobe of thyroid. Okay, so if it's a tumor of the deep lobe of parotid gland. Okay, so if the deep lobe of parotid gland is involved, it looks like a dumbbell, and similar dumbbell presentation here also. Okay, dumbbell shaped, extend to the anterior triangle of the neck, right? So neck swelling, endolaryngeal swelling. Okay, balls in the false vocal cord and aryepiglottic fold. So it can also transfer into malignant condition. Okay, and sometimes is associated with the laryngeal CA itself. Next is, of course, it is present at the area of false and true vocal cords. So hoarseness of voice, increase in the swelling size during valsalva. Okay, stridor can be there. If the stridor, it's usually seen in the endolaryngeal laryngocele. If it's obstructing the airway, there can be stridor, and they can also turn into infected condition, which is known as piacile. Okay. So you can see in the flexible laryngoscopy, what you can see is the swelling of the false vocal cord and aryepiglottic fold. Swelling easily emptied, escape of the purulent fluid into the airway, which is known as piacile. Okay, so you can go for an X-ray neck AP view. You can see this black shadow, which says you that this is the air-filled radiolucent swelling. Okay, air-filled radiolucent swelling. How are you going to treat a case of laryngocele? So if there's no symptom, no treatment is required. If it's an infected, you have to go for aspiration and antibiotics. The treatment is how are you going to treat is you have to go for marsupialization. Remember, marsupialization was also a treatment for ranula and plunge-in ranula. Okay, where you just where you cut open the sublingual gland, you aspirate the fluid and just cut open and stitch it toward the periphery. That is known as marsupialization, right? So external laryngosele, excision by external approach, cyst exposed by removing the upper half of the thyroid cartilage. Cyst inside as its neck and it is stitched. Okay, it is stitched. So of course you need to remember that hypopharyngeal pouch also I have discussed, and of course laryngosele also I have discussed now. Okay, now laryngosele, the most important thing whenever it comes to laryngosele, you should not forget trumpet blowers. Number one, you should not forget next topic, which is it is more common to glass blowers. Okay, next, what should you not forget? You should not forget that laryngosele can be infected, which is known as pyosele. Very good. What next? Not to be forgotten, laryngosele can actually be associated with laryngeal carcinoma. Okay, it can be endolaryngeal, extralaryngeal, or it can be combined. Okay, dumbbell shaped. Okay, now next is brachial cyst. It's very, very, very important topic, and so difficult to understand is brachial cyst. So we'll talk about brachial cyst first, and then we'll go to thyroglossal cyst. Okay, so we'll continue with brachial cyst and thyroglossal cyst in the next video. Okay, thank you. Hello and welcome to everyone again. So now we are starting with the brachial cleft cyst. Okay, so there are three basic important terms. One is a brachial cyst, other one is sinus, and other one is a fistula. So it's very much important for you to understand what is a sinus, what is a fistula, and what is a brachial cleft. Okay, so normally what you need to understand is, if you look into this diagram, that towards this outside, you can see here this is the external acoustic meatus, right? And here inside what you have is, this is the palate and tonsil over here, and here you have the external brachial fistula. It has an opening along with the tonsils. Okay, so what you need to remember is, whenever we talk about fistula it has two openings. Okay, sinus, it has one opening, and cyst or the cyst or swelling, it's basically a mass. Okay, over here it should regress on time, but if it doesn't regress, there'll be a problem. Okay, so let's understand this. Cyst is actually a remnant of brachial cleft or pouch without internal or external opening. So it's just a mass. Okay, it does not have an internal or an external opening, it's just a mass. Okay, and remember, sinus is a persistence of the cleft with the skin opening. So in sinus, what do you have? You just have an opening, but just one opening. It's a blind sac. It does not have an insidal opening. Okay, and fistula, it is persistent of both cleft and pouch with opening in the skin and in the pharynx. So cleft and pouch means there's opening over here also towards the cleft also, and there's opening towards the pouch also. So there is a communication between the opening of the cleft and the pouch, and that communication which has occurred, it is known as a fistula. Okay, so arise from the failure of complete development of the brachial apparatus, including the first, second, third, and fourth arches. So what do you have? You have first arch, second arch, third arch, fourth arch. Okay, and then you have the sixth arch. There's no fifth arch, right? There's sixth arch. You need to remember that during the fourth week of development of the intrauterine life, 6 brachial arches develop as neural crest migrate cranially. During the 5th week, the second brachial arch grows over the third and fourth brachial arch, forming a cervical sinus. Failure of the cervical sinus to close allows the potential communication with the second pharyngeal pouch in the area of the tonsillar fossa, in the third pouch in the area of larynx, and the fourth pouch opening in the piriform fossa. So what does this mean? This means if that communication is not blocked, if that communication persists, if that communication is associated with the first pharyngeal pouch, if it's a first
cleft disorder, opening will be at the base of your EAC, number one. Number two, if it is associated with the second brachial pouch, then the opening or the second fistula, the opening will be in the tonsillar fossa. If it is associated with the third, it will be in the pyriform fossa. Pyriform fossa. Fourth, there will be pyriform fossa. Okay, pyriform fossa, third is the base, fourth is the apex. First brachial cleft cyst. The external opening is in the neck, varies in position but lies in the line between the tragus and the hyoid bone. So, in between the tragus and the hyoid bone, there's an opening. Type 1, it contains only ectodermal elements without cartilage or adnexal tissues structures and are present medial to the concha. That means it is somewhere over here. Actually, if there is a fusion defect, the first brachial cleft and the second brachial cleft must fuse at the area of incisura terminalis. If there is no fusion, there is preauricular sinus. Okay, preauricular sinus is a blind sac, right? Basically, this is made up of, the only tragus is made up of second arch. Others all are made up of first arch. Tragus, it's actually made from the sixth hillock of His. This pinna, it's actually made from the hillocks of His, isn't it? So, type 2, it contains of the ectodermal and mesodermal. Both components are there in type 2, ectodermal as well as mesodermal. It is present ectodermal as well as mesodermal, and it is present below the angle of mandible. Second brachial cleft cyst. It's a commonest brachial anomaly. It's a painless, fluctuant mass along the anterior border of the midline, middle 1/3 of the sternocleidomastoid muscles. Okay, so there's a painless, fluctuant mass along the anterior border of the middle 1/3 of the sternocleidomastoid. So over here, along the anterior border of the 1/3 of the sternocleidomastoid. And what do you need to remember? Fistula tract, it opens into the tonsils, right? So just remember that I'm making it for one diagram. 1, 2, 3, 4 for remembrance purpose. Remember that this is your external carotid, this is your internal carotid, this is your superficial laryngeal nerve, this is your recurrent laryngeal nerve. Okay. So fistula tract opens externally along the 1/3 of the sternocleidomastoid, passes deep to the second arch structures. So this second arch structure, deep to the external carotid, superficial to the internal carotid, and ends internally in the tonsillar fossa. You just need to know superficial and deep. Okay, there are all other things. And third brachial cleft, it passes deep to the third arch structure, that is internal carotid, and superficial to the superficial laryngeal nerve. Remember, over here, this is your third brachial arch, third brachial cleft. And fourth brachial cleft means it runs deep to the fourth arch structure like superior laryngeal nerve and superficial to the recurrent laryngeal nerve. Suppose your mass is over here. So how can you remember? See, you just need to remember 4 structures: superficial and deep, superficial and deep. It's so easy. Second brachial fistula, if it's a second brachial fistula, it lies deep to the external carotid, above the internal carotid. And if you talk about the third brachial, it lies deep to the internal carotid, superior to the superior laryngeal nerve. If you talk about the recurrent laryngeal nerve lies deep to the superior laryngeal nerve and superficial to the recurrent laryngeal nerve. Okay. Treatment. Before treatment, if it's a sinus, go for a sinogram. If it's a fistula, go for a fistulogram. Okay. Abscess treated first with incision and drainage plus blood-stictum antibiotics is given. Elective surgical excision of the cyst with its tract traced up to the origin in pharyngeal wall done after infection resolves. Okay. Brachial fistula excised with 2 placed origins. So there is a step ladder approach. So usually this brachial cleft and brachial fistula, it's very difficult to understand. Just understand that you have three terms. One is sinus, one is sinus, one is cleft, other one is fistula. Sinus, fistula, and cyst. Okay. Whenever you talk about a cleft, it's an ectodermal component. Pouch, it's an endodermal component. The middle one, this brownish component, middle one, this is actually a mesodermal component. And at the area of meeting, okay, at the area of meeting, you can see here, which I'm marking with black, okay, this area of meeting is actually from the ectoderm and the endoderm and some part from the mesoderm, right? And this area is the area of tympanic membrane. At the area which I'm marking with black, this area is the area of tympanic membrane. That is why tympanic membrane is made from all the three layers: ectoderm, mesoderm, and endoderm. So this completes our video on brachial cleft cyst. Next.
Hello everyone. So now we are at the last of this topic, and our topic for today is thyroglossal cyst. So thyroglossal cyst, usually a presentation, it's seen in children or maybe still seen in slight pubertal age group, maybe seen in adults. Okay, so it's a condition where there is an aberrant communication. Usually the thyroid, it is formed at the area of the base of the tongue. It's the primitive origin is there, and from there it tends to descend down to lie in front of your trachea. Okay, so so it lies in front of your trachea. But if there is a persistent communication between the base of the tongue and the thyroid gland, and this is known as a thyroglossal cyst. So talking about the presentation is basically there will be a swelling on the anterior aspect of your neck. There will be a swelling, and the swelling, midline swelling, this is known as midline swelling, and this swelling tends to move with deglutition as well as protrusion of the tongue. Okay, so there are different other swellings which tends to move with the deglutition or with the swallowing. Okay, so these are actually thyroglossal. One is thyroglossal cyst. Okay, the other one is being the thyroid swellings, the thyroid swelling also. Then there is a pretracheal and prelaryngeal lymph node. Okay, and there is also subhyoid bursitis, and there is midline dermoid. Okay, so these are the condition where there is movement with respect to swelling. Okay, and then one more thing that you need to remember, that thyroglossal duct cyst, it is congenital, and the age of presentation is 15 to 30 years. So it might be presented in the pubertal, or it might be present after birth. After a certain time it might be presented. Remember that this thyroglossal cyst, it's a communication like this, right? So this may be infected, and if it's an infected cyst, then this is known as thyroglossal duct cyst abscess. Okay, and if you externally incise and drain it, it will lead to a formation of iatrogenic fistula. So you should not do that. Okay, so you have to actually excise this completely, and you have to go for the body of the hyoid bone excision, because there is subhyoid, suprahyoid. Okay, this location can be there. And one more thing that I would like to add upon here on thyroglossal cyst, we will look into the slides, don't worry, that there are different locations, but the most common location is on the area of the hyoid region. Subhyoid, suprahyoid, I'll tell you in certainly. And the operation that is done is a cyst trunk operation. Okay, it's known as cyst trunk operation. So let's move on to the slides. So thyroglossal cyst, thyroid appears as epithelial proliferation in the floor of mouth, as I already told you, towards the base of tongue, towards the mouth. Thyroid descends in front of the pharynx as a bilobe diverticulum connected to the tongue by a thyroglossal duct. Okay, so it's connected by the help of thyroglossal duct. The duct normally disappears later. If it persists, that is known as thyroglossal duct cyst. Commonest congenital anomaly of the thyroid. So there can be lingual thyroid, there can be ectopic thyroids, but there can also be thyroglossal duct. Okay, the descending thyroid can persist anywhere between the foramen cecum. I hope you know this part. Suppose this is your tongue. Here, this one is a foramen cecum. Here you have the papillae, right? Foramen cecum. So from the foramen cecum to the thyroid isthmus, infection in the tract leads to simultaneous epithelial remnants, so that they undergo cystic change. The tract includes proximity to the hyoid bone lying within the periosteum or even passing through the bony substance. What does that mean? That means it passes through the to the hyoid. I already told you initially also, it is in close communication with the hyoid bone. That is important to understand. Okay, so it can be the incidence of thyroglossal cyst. It can be 2% can be intralingual, 24% suprahyoid, 61% thyroid, 13% suprasternal. So this is one of the landmark, but much more important to it will come in the next slide. So it's an equal sex distribution. So from birth to 70 years, peak at 5.5 years, 90% midline. I told you midline swelling, which moves with deglutition. Okay, so commonest site is the subhyoid. As I told you, there is a high communication with the hyoid. Which part of the hyoid? Subhyoid. Okay, subhyoid. Okay, not suprahyoid. Subhyoid, suprahyoid. It can be interlingual, okay, or it can be to the base of the tongue. There can be various communication. This diagram is taken from Bailey and Love. Okay. So next thing that you need to remember is other sites is base of tongue at the level of thyroid cartilage, sublingual. Least common is at the level of cricoid cartilage. At the area where the larynx ends, so that area it's least common. Okay. So first, recurrent inflammation of the throat or surrounding lymphoid tissues stimulate the epithelial remnant of the tract that will undergo cystic degeneration. Second, there is a retention phenomenon. Blocked thyroglossal duct at the foramen cecum accumulates the secretion, formation of a cyst. Okay. I already told you this one. So we will continue in the next slide. Okay, next session.